Welcome to our June Environmental Health Seminar. My name is Tina Chen, and I'm one of the Environmental Health and Knowledge Translation Scientists at the NCCEH. So just a few housekeeping items to mention before we start for people on the phone. If you're attending as a group on the phone, because I can't see online who's actually attending with you, please type in a chat box how many of you are in your group. And on the same note, since I can't see who's in your group online, if you would like to receive Sci-Fi educational credits, please email me. I will put my email address in the chat box. So during the question and answer period after the presentation, please enter your questions into the chat box, and we'll answer your questions verbally. So today our guest speaker is Tissa Rahim, who is a project coordinator at the BC Center for Disease Control. Tissa is a project coordinator with the Environmental Health Services at the BC CDC. She has been working closely with data from the Drug and Poison Information Center. She is also the co-lead of a national project that aims to enhance data quality and comparability across the 5 Canadian poison centers. Tissa obtained her MSc in pathology at the University of British Columbia and has been working at the BC CDC since January 2017. Thanks, Tissa.
Thank you so much, Tina, for the introduction, and thank you everybody for attending the talk today, which will be covering calls to the British Columbia Drug and Poison Information Center before and after cannabis legalization. So just to give a bit of a background on the project, as I'm sure we're all aware, cannabis was legalized in Canada on October 17, 2018. So the sale of certain cannabis products became legal, and these include fresh and dried plants, seeds, oils, and pre-rolled joints. Certain things still remain illegal, which is edibles, unless you were to make those edibles with one of the legal products that you can purchase already. Vape juices are still illegal, as are concentrates and dermal creams. So the reason that we got interested in examining cannabis calls coming to our poison center is that in U.S. states where cannabis was legalized, the poison centers reported an increase in the number of calls about cannabis exposures. And this was both comparing in the state pre- and post-legalization, as well as comparing between states that had legalized cannabis versus ones that had not yet done so. And what was especially found was that there were a lot of calls about children accidentally consuming edible products. So with that in mind, we were wondering whether we would observe similar increases in BC if we were to look at our calls before and after cannabis legalization. So here is a simple schematic of the call workflow at the BC Drug and Poison Information Center, which is also called DPIC for short. So at DPIC, the staff, which is especially trained pharmacists and nurses, can take calls from either the public or from healthcare professionals. If the call is from the public, it can either be the public can either directly call the poison center, or they can be rerouted through a helpline such as HealthLink. And so at the poison center, the poison information specialists advise either the public or the healthcare professionals on the exposure that is being described, and enter the information in a call history database. And the call database consists of 2 separate components. The first one is a set of coded fields that have standardized drop-down options that the poison information specialist can select. So here are 3 examples of those types of coded fields, which is reason for exposure, exposure site, and caller site. Each case report also has a case history notes section, which is where you'll find more detailed information on the case and how the case was managed. So here is an example of a typical cannabis call to DPIC. At the top of the report, you will find the date of the call and the date of the exposure, as well as any demographic information that may have been given to us by the caller. So here, for example, it's the age and the sex, a 44-year-old female. The caller name, the city, as well as where the person's calling from, and in this case, the person is calling for themselves. And then below, you find the information on the substance that the person was exposed to. So in this case, it was a marijuana brownie that the person was exposed to. And once you look into the detailed case history notes, we see that a healthy 44-year-old woman ate 1 brownie containing marijuana, and her symptoms are described as being drowsy and lethargic. So the advice from the poison information specialist is for her to have a friend stay with her, and that she should be improving slowly on her own. And they also agree for the poison information specialist to call back at 2. And then, so after this is the section where the person called back, and they're now saying the person is dehydrated but feeling better, and the case is closed. So on the second page of the report, you will then find any symptoms that were mentioned, any treatments or lab values, which there were none in this case, as well as things like the a medical outcome or the reason for the call at the end of the report. So the way that we went about identifying our cannabis exposure calls is that we first restricted the years to 2013 to 2018. And the reason that we went back to 2013 was because that was the first year where calls were consistently recorded in the electronic database. So we had a 2-pronged approach in identifying our cannabis exposure calls. The first one was using one of the, I believe there's 13 or so generic codes for cannabis. We searched for all of them in the DPIC database. So these generic codes can include things like cannabis dried plant, cannabis edible formulation, or cannabis topical oils, things like that. So we gathered all of those cases. And what we also did is, knowing that the data at DPIC can potentially have some data quality concerns, we also collected a set of key terms and synonyms for cannabis. So we ended up having about 40 keywords. So things like Mary Jane, marijuana spelled with an H instead of a J, for example, 40 different synonyms for cannabis. And we performed a free text search in the cases that did not have a cannabis code with one of these generic codes. And so we also ended up including those in our completed data. So our inclusion criteria was if there was evidence of cannabis exposure in the case history notes. We excluded any cases where the call was specifically just to seek out information. So sometimes we get, for example, a pharmacist might call to DPIC and ask to get any information on whether, a cannabis medication might interact with another medication. In that case, the call isn't really about an exposed person, so that's considered an information call at DPIC. We also excluded calls where the only evidence of cannabis was through a toxicological screen. So for example, if a doctor calls and they're saying that they have a patient in and they did a urine test and the urine test came back positive for THC, if that was the only evidence for cannabis in that case, we excluded it because we had no evidence as to when the cannabis was taken. We also excluded calls about animals exposed to cannabis. We had about 3 cases that were coded with one of the generic codes for cannabis, but upon examination of the case notes, we didn't find any evidence for them, so we excluded those. And finally, we focused our data analysis on calls within BC. So prior to doing our data analysis, we actually underwent a bit of a data quality assessment. And another thing that we did, which is actually unique as far as we know in terms of the way Poison Center data has been utilized, is that we created a set of standardized fields using information from the case history notes to allow us to better understand the cannabis exposure. So first, starting off with fields that already exist in the DPIC database, we assessed these for data quality and determined that their data quality was useful and we were able to retain them as is. So these include some of the demographic fields, some of the symptom and treatment fields, as well as the medical outcome and caller type fields, for example. The second thing that we did is we used fields that already exist in the DPIC database and expanded them for the purposes of understanding the cannabis exposure better. So at DPIC, every substance that the patient is exposed to is listed separately. And what we did is we looked through those and we categorized them according to what the patient took with the cannabis. So cannabis plus alcohol, cannabis plus illicit drugs, as well as cannabis with psychoactive medications and other harm substances or over-the-counter medications. We also looked at whether the exposure was in a public site or a private location. And we also broke down cannabis exposures by the route of exposure, so whether the person was exposed to a smoked, edible, or medical formulation of cannabis. And we also broke down who was calling on behalf of the person, or if the person was calling for themselves. So these are the new fields that I mentioned a few slides ago. So these were abstracted from the case history notes and standardized where the information was available. So these included the purpose of cannabis use, so whether the cannabis was used for medical purposes, for recreational purposes, or for other reasons, or, for example, an accidental exposure. We also recorded the motivation for the call to the poison center. So if most of the time this was a person trying to manage their exposure to cannabis and the symptoms that they were experiencing, but sometimes we also got calls about secondhand exposures, and we also got calls where a person had taken cannabis and was now wondering whether they were allowed to take their regular medications or if there would be any interaction issues. We also recorded the source of cannabis, where it was available. So this was broken down into friends, family members, as well as stores or things like the 420 festival. We also recorded the past history of cannabis use, so whether the person was an experienced user or a novice user. As well, and this was sort of unique to cannabis cases, some of the symptoms that people were describing on the phone were things like high and stoned and intoxicated, for which DPIC doesn't actually have codes. And so we just decided to also record those and see how often we get those kinds of symptoms described. And also just to mention, for the purpose of time, I unfortunately won't be able to present on all of those fields, but we just selected some key ones. So to start off with a general idea of the number of cannabis exposure calls over time, here we have a graph where the y-axis represents the number of calls and the x-axis is the years. And the numbers represent the proportion of cannabis calls, so the cannabis calls as a proportion of all calls to DPIC in that year. So as you can see, from 2013 to 2018, we had a tripling in the number of cannabis exposure calls to DPIC, with just over 200 in 2013 and just over 600, or actually about 650 or so in 2018. As well, not only did the numbers go up, but also in 2013, cannabis exposure calls made up about 1% of all calls to DPIC, but in 2018, they made up 2.3%, so we saw quite a bit of an increase in the proportion of cannabis exposure calls reported to DPIC. So this is the same time series plotted out month by month from January 2013 to December 2018. And this is to further elucidate the changes in the calls that we're seeing over time. So as you can see, from 2013 till about 2015 or so, we're seeing that the calls about cannabis are increasing, but that this increase is relatively stable. It's not going up very quickly. However, once you get to about the end of 2015, we start to see an inflection point, after which the rate of cannabis calls appears to be more rapid than it was in the previous time period. So in order to allow us to understand what might be influencing this, we decided to overlay this graph with some key dates that preceded cannabis legalization, just to put that into context. So at the end of 2015, we saw the election of the Liberal government. And as we know, one of the first things that was announced after the election was the creation of a federal, provincial, territorial task force for the legalization and regulation of cannabis. So this task force got together and released a set of recommendations at the end of 2016, so a year later. Following this, Bill C-45 for the legalization of cannabis passed in the springtime of 2018, and this was followed by cannabis legalization in October 2018. So what's interesting here is that this rate increase is coinciding with some of these key dates for legalization. And another interesting thing that we observed here is that we see an almost cyclical pattern happening after this date at the end of 2015, where we see peaks at the end of the year followed by valleys in the late spring of each year, which seems to again be correlated with some of these key dates for cannabis legalization. So to break this down a little bit further, we decided to also plot out the months that preceded the cannabis date, the date for cannabis legalization, and the month after for each year to see what the pattern for that looks like. So the gray bars are all cannabis calls that year, and then these are the couple months before and a couple months after cannabis legalization for the cannabis legalization date. So as we see, throughout the years, we actually always do see an increase, a higher number of cannabis calls coming in at the end of the year rather than the third quarter of the year. But this does seem to potentially be going up a little bit starting in 2016, where we start to see more calls coming in at the end of the year as opposed to the September to October period. But overall, we do see that this trend is something that occurs in basically every year examined. And to elucidate this time period even further, we decided to also illustrate the percent of calls that we got in each of these periods of the key legalization dates for cannabis, and how much of the percent of the time period that we examined for our study they made up. So, for example, the January 2013 to the end of 2015 date, which was the pre-election of the Liberal Party, while this made up 48% of our time in the study period, we got about 33% of calls in this period, which is a ratio of 0.7. Going up ahead in time, we find that starting at around the time when the task force recommendations occurred and up till the announcement of Bill C-45, we get a reverse in that ratio, where the percent of time that period makes up in our study is lower compared to the percent of calls that we get in that period. And finally, in that post-legalization date of October 17th till December 2018, while this period only makes up 2% of the period of calls the period that we examined, we get 7% of our calls in this period, with a ratio of 3.5 as compared to 0.7 in the earlier time period. So the next couple of slides are going to be breaking down cannabis exposure calls by various different demographic factors, starting off with age groups of interest. So here we've got children 12 years and younger, adolescents 13 to 18, adults 19 to 49, and adults 50 years and older. What the graph shows here is, on the y-axis, is the number of calls, and the white numbers that are overlaid are the proportion that each of those age groups makes up of all the cannabis calls in that year. So as you can see, we're seeing an increase in the proportion of calls about children over time, from 4% in 2013 to 10% in 2018. And we see this we also see an increase in the calls for adults, so from 34% to 39%, as well as for adults 50 years and older, going from 10% in 2013 to 15% in 2018. The only age group where we're actually seeing the reverse trend is for adolescents, 13 to 18, where in 2013 they made up 32% of our calls, and now they make up, in 2018, they made up 16% of our calls. So overall, cannabis exposure calls are proportionally increasing for all age groups except for the adolescents, where they're actually decreasing over time. Broken down by gender, we see that in 2013, calls about males were slightly higher compared to females, but these proportional numbers actually start to even out by 2018, where we actually get the same number of calls about women as we did about men. So and this change occurred over time. So at this point now, we've got an equal number of calls about males as we do about females compared to 2013. Broken up by health authority of interest, we saw that the highest change in the relative proportion was in the Vancouver Island Health Authority with 6%, with a 6% increase over time, followed by Vancouver Coastal and the Interior with 4%. We actually saw that the Northern Health Authority started off with a high rate of calls to DPIC, which then started to decrease, and the percent change was actually a 12% reduction over time. We also see a reduction in the relative proportion coming from the Fraser Health Authority, even though we're seeing an increase in the rates. And this discrepancy is because our denominator for our percent change calculation was increasing faster than the numerator for that health authority, meaning that it gave us a negative percent change in relative proportion over time. So this slide breaks down cannabis exposure calls by the source that the person attained the cannabis from. So these were broken up into friend, which is a category that also includes acquaintances, neighbors, and friends. Homemade, online, prescription, store from a stranger, or an other field, which is mostly the 420 calls that we got, which is the 420 Cannabis Festival, So as you can see, overall, in most of the calls, the cannabis was described as having been obtained from the friend category. But an interesting thing that we see is that the proportion of calls about store-bought cannabis are going up over time the most, only making up 0.4% of calls in 2013 and 8% in 2018. And another interesting thing is that we're starting to see a small proportion of calls about online purchases popping up starting in 2017. And calls about prescriptions are going down over time from 6% in 2013 to 2% in 2018. This next slide breaks down our cannabis exposure calls by the vehicle. So here we categorize cannabis into 3 different categories, which is the first one is smoked. So this is exposure to cannabis via inhalation. Edible, which is exposure to cannabis that was contained in a food or beverage product. And we also had a category which we loosely termed medications or medical, which was exposures to pills, tablets, capsules, concentrates, nabilone, which is a synthetic cannabinoid that is prescribed, as well as tinctures and oils and anything similar in nature. So what we found over time is that our calls about smoked cannabis were decreasing. So in 2013, they made up 43% of our calls, and in 2018, they made up 33% of our calls. And the reverse trend was happening for edibles and our so-called medical cannabis products. For edibles, in 2013, they made up 24% of calls, and in 2018, they made up 38% of calls. And for medications, that was 9% in 2013, and an increase up to 21% in 2018. So we decided to split each of those exposure routes down into the specific products that the person mentioned on the call that they used or that they were exposed to. So starting off with the smoked cannabis products over time, we thought we would look specifically and see if we're seeing any changes over time for these products. And we didn't really see anything change over time with the exception of the secondhand cannabis exposures, which made up 7% of calls about smoked cannabis products in 2013. But in 2018, we didn't receive any calls about secondhand cannabis inhalation. And from our calls, we found that most of the time when the call was about adolescents, the call was about smoked cannabis products. So we decided to look specifically what smoked products adolescents were exposed to in that time period. And as you can see, for the most part, the specific product was unspecified. And this is because a lot of times when people are calling about having smoked cannabis, they just say, I smoked some cannabis, smoked weed, I got high. They don't really explain how they did it. But when that information was available, for the most part, we got calls about joints, followed by bongs. And we also got the appearance of concentrated products, including shatter, or a description that the marijuana was dabbed, which is usually how concentrates are consumed. And interestingly, while vaping is a big public health topic right now, we only had a few calls about cannabis vaping products over this time period. So going to the edibles that were reported to DPIC, what was interesting was that in 2013, brownies and cookies made up the large majority of our calls about edibles, but these have decreased over time. So brownies only made up 13% of our calls in 2018, and cookies made up 24%. And interestingly, whereas in 2013 we got no calls about candies or gummies, these now in 2018 made up 29% of all calls about edibles. So edibles are a particular concern to young children due to their palatability, and it was what we found with our cases was that a lot of the calls about children were about children accidentally eating edibles that had cannabis in them. So we decided to look at this age group in more detail and look at what edibles they were exposed to. So for the most part, children 12 years and younger were exposed to cookies and candies and gummies. As well, we got some calls, and this was especially true for very young kids, like toddlers, where the parent may have found the toddler with a joint in their mouth or a little bit of ash from a marijuana joint. Also, we had a call about a kid eating a couple of pieces of the concentrated shatter or drinking cannabis vaporizer liquid. So that's this other category. And interestingly, looking at this age group over time, we see that in 2016, we start to see this appearance of candies and gummies, which we didn't see at all from 2013 to 2015. And by 2018, calls about candies and gummies make up almost the same proportion as any other type of edible for this particular age group. So in terms of the medical cannabis products that we saw at DPIC, the majority of our calls used to be about nabilone, which is the prescribed synthetic cannabinoid. These made up 64% of our calls in 2013. But this has drastically decreased over time. In 2018, we only had 4% of our calls being about nabilone. And instead, what we're seeing now is an increase of calls where the person is described as having been exposed to something like a capsule, a combination of THC and CBD in whatever form, as well as oils. So these three have all increased quite drastically over time. So a lot of our calls about these so-called medical cannabis products came from seniors. So we decided to break down what specific products seniors were exposed to. So here we see that the majority of the time, seniors were exposed to oils, but also to nabilone and to those capsules, tablets, pills, and lozenges. And interestingly, looking at this over time, we see that in 2013, 60% of our calls were about nabilone, so more than any other medication. And in 2014, we start to see the appearance of oil products being reported to DPIC, and nabilone is actually was not even reported in 2018. And oils make up almost the same proportion of calls for seniors as any other medication that we saw at DPIC. This next slide breaks down cannabis exposure calls by user familiarity. So this is whether the person had previously used any form of cannabis or if this is their first time using any form of cannabis. Since this was a field that we abstracted from the case notes, the information was not available in 47% of cases, but where it was available, we actually had an interesting result. We thought that we would see more calls from novice users as compared to previous users, but we actually found the opposite, where we're seeing consistently more calls from previous cannabis users as compared to novice users. There was a small subgroup of previous users of cannabis that were calling DPIC because they either got the cannabis that they normally use from a different source than they usually do, or they were used to one kind of cannabis and were now calling because they took another kind of cannabis and were experiencing adverse effects. So most of the time that was a person that is used to smoking cannabis and took an edible and was feeling adverse effects as a result of it. And also for our novice users, there was a majority of calls about edibles as compared to medical cannabis products or smoked cannabis products. So the next couple of slides break down the medical outcome of cannabis exposures by the age group of interest, so starting off with children 12 years and younger. At DPIC, if a case can be followed to a known outcome, it is coded with a clinical outcome that can range from no effect to minor, moderate, and major. So minor being an outcome that is minimally bothersome and will typically resolve quite quickly, to a major effect, which is an outcome that can be life-threatening and that may result in residual disability. So looking at children 12 years and younger, we see that in 2018, the majority of cases reported resulted in a minor clinical outcome followed by a moderate clinical outcome. A similar trend was observed for adolescents 13 to 18 years old, where overall and over time, most experienced minor clinical outcomes, again followed by moderate clinical outcomes. For adults 19 to 49 years, again, similar, 50% of calls in 2018 were coded as having a minor clinical outcome and 32% as a moderate. What was interesting and unique to this particular age group was that if we isolated cases where cannabis was the only substance that the person was exposed to, so they didn't take any other substances in addition, we saw an increase in calls being reported as having minor clinical outcomes as opposed to moderate. So we kind of see a shift in the proportion between these two. And that trend can be further elucidated in putting the graphs side by side. So here you see when cannabis was taken in combination with other substances, there are more calls coded as moderate and fewer calls as minor in comparison to calls where cannabis was the only exposure substance, where we see more calls being coded as minor and less as having a moderate clinical outcome. And finally, for older adults, 50 years and older, similar again to the other age groups, most of our clinical outcomes reported were minor, followed by moderate. So to summarize what I've shown you here today, looking at cannabis calls from 2013 to 2018, we found that our calls to DPIC tripled between 2013 and 2018, going from just over 200 calls in 2013 to about 650 calls in 2018. The proportion of calls about young children, 0 to 12, and women increased. So for children, it was from 4% to 10% of our calls, and for women, it was from 45 to 49%. And the proportion of calls from Vancouver Island increased the most, going from 15% in 2013 to 21% in 2018. The proportion of calls about edibles and medications increased as compared to the calls about smoked cannabis products, which actually decreased over time. For edibles, we saw an increase from 24% to 38%. And we especially started to see candies coming up and becoming a particular concern. And for medications, we saw an increase from 9% to 21%. And what we saw especially increase is oils, capsules, and descriptions of combinations of THC and CBD products. We saw an increase of cannabis products being obtained from stores or from an online purchase. And we also found that when taken with other substances for adults, the proportion with more severe clinical outcomes was higher as compared to calls where cannabis was taken on its own. So to kind of discuss what all these results mean in terms of the context of public health and things like that, what I showed you early on in the presentation is that we saw a consistent increase in cannabis calls that went from between 2013 to the end of 2015 and became more rapid starting in 2015, which was concurrent with some of those key legalization dates for cannabis. And the other interesting thing that we saw was that seasonal pattern that was observed, where we saw peaks at the end of the year starting in 2015. What we also found was that the majority of calls that we got to DPIC over this time period were as a result of products that are not yet regulated, purchased from stores, which were actually illegal storefronts or online websites that were not like government websites. So most of the adverse effects that were being reported to DPIC was as a result of these kinds of products obtained from from illegal storefronts. Another big reason for calls to DPIC was young children accidentally being exposed to edibles that most of the time were lying around in like a parent's home or a family member's home. And when used alone, cannabis was most often resulted in a minor medical outcome for adults, meaning that cannabis on its own for adults usually was something that could be managed at home and didn't really require healthcare facility utilization. And in terms of why we're potentially seeing these changes in the cannabis calls, we would like to propose that this is likely more a result of continued normalization of cannabis use rather than those key dates that were presented earlier on in the presentation. And this is because legalization was also co-occurring in U.S. states at the same time. So I believe right now there are 9 U.S. states where recreational cannabis has been legalized, and about 22 more where medical cannabis is legal. And the earliest legalization of cannabis was in Colorado in 2012. At least in urban areas, we saw a lot of dispensaries popping up during the time period that we studied. So in Vancouver, for example, from 2013 to 2015, we saw a 100% increase in cannabis storefronts per year. And in the first half of 2015 in Vancouver, there was an increase of increase in dispensaries going from 60 to 100 in the first half of 2015. There was, again, in more urbanized areas, there was minimal police enforcement, mostly because there were other more pressing matters to deal with, such as the opioid crisis. There has also been an increased acceptance of legalization throughout the entire country. And particularly BC has been known for a long time to be very cannabis friendly when it comes to, in comparison to our neighbors. As well, as I mentioned before, the majority of the adverse effects that are reported to DPIC are more due to the appearance of new cannabis products, leading to it emphasizes the need for having a regulation of these kinds of edibles and medical products, such as standard dosing, and educating people on how to take these products. So, for example, for edibles, we had a lot of calls where a person was double dosing because they took one dose, waited, but not long enough for the edible to kick in, and then took another dose, and as a result started experiencing adverse effects. So some education around that needs to be implemented, as well as safe storage for children and making perhaps products that are less appealing for young kids to get into. With that, I would like to conclude my presentation. And thank you so much for listening, and thank you to everybody who was involved in this project. This includes the staff at DPIC, including Dennis, Leon, Deborah, Victoria, and Roy, as well as Emma, Adrian, who helped with the epidemiological work and the data collection, as well as Sarah Henderson and Tom Guzetsky. Thank you.
Thank you, Tissa. So I guess we'll start with questions in the room first. And for those of you online, if you could put your questions into the chat box, we'll get them accordingly. So do we have any questions today? Sorry, you can come up to
Thanks. Interesting. You mentioned that toward the end of 2018, there were 3 cases of vaping-related calls. Do you anticipate that number to keep going, given what you said about the trend toward vaping practices? And if so, just realizing that some of the vape cartridges that might be around in the marketplace have illegal fungicides like myclophenol, which upon high heating will produce hydrogen cyanide. So the question relates to that aspect of vaping then, that if there were incidents of individuals vaping cartridges that have high amounts of hydrogen cyanide or various amounts, how should Drug and Poison Information Center be alerted to those kinds of sequelae, clinical sequelae, where right out the bat you would suspect that that is the situation, that it came from a vape. There's other substances in there that lead to clinical effects.
That's interesting. I think I actually read that article today as well. It was sent around this morning, right, with the cyanide. So to answer the first half of that, I do think that potentially we're going to start to see more of an increase in cannabis vaping products coming through. We actually just published an article on e-cigarettes, e-cigarette calls coming through DPIC, and there was also an increase in those over time. So I wouldn't be surprised with now cannabis vaping products also becoming trendy and popular, us seeing that as well. And maybe a lot of times it's not even because of the symptoms of the cannabis that they're experiencing, but because of device malfunctions or spilling the juice on themselves and stuff like that, which is what we saw for the e-cigarettes as well. And we also saw cases where children would be drinking the juice, especially, I don't know if it's going to be flavored in those appealing ways like the e-cigarette cartridges were, but if they are, then that's definitely another concern. If the concern is the cyanide exposure, I would actually think that that would become the priority for the poison information specialist on the call, and that would actually be the primary thing that they would try to deal with rather than the cannabis exposure, because the cannabis would probably most likely be considered relatively harmless in comparison to inhaling the cyanide. So I assume we would have to, so if, for example, if the person is calling and they say that it was a vaping product that they were exposed to, perhaps to consume the cannabis, perhaps the first thing that the poison information specialist, the first thing that they could rule out is potentially whether or not they were exposed to the cyanide. Maybe there's some kind of set of symptoms that people that are exposed to cyanide are often exposed to. I would feel like you'd probably want to rule that out first, and I would assume that depending on how severe the symptoms are and how often they've been exposed to it, there might have to be some healthcare facility use down the line, like they might recommend for them to go to the hospital, which they probably wouldn't if they were just exposed to cannabis alone and if it was an adult.
Okay, a couple questions online. You mentioned that you're working on a project to improve data quality and comparability across the poison control centers in Canada. Could you tell us a little bit more about the project?
Sure. So this project is called the Canadian Surveillance System for Poison Information. So the overall goal of the project is for us to be able to utilize data from the 5 Canadian poison centers and feed them all into one federal system, the data for which can then be used for surveillance and research purposes and to inform public health and policy. We went into this knowing that poison centers have both inter and intra variability in data quality and in some of our practices. So what my role in this has been is I co-lead one of the subgroups of the CSPI project, which is called the Data Quality and Comparability Working Group. So what we do is, the first thing that we did is we conducted some site visits at the 5 different poison centers, and we got a better understanding of what some of the data quality concerns are and what some of the differences in practices are. And what we're currently doing actually is we are creating chart audits for, especially currently for some of those coded fields that I talked about before, and to get a sense of sort of a baseline measure of what our data quality looks like. And we work hand in hand with the training working group. So we, for example, say the reason field is there are some issues here across the sites or specific to this site. And the training group then designs strategies to improve the way that that field is coded, thereby also improving our data quality. And then we also work closely with the surveillance working group, which gives us the priorities for what fields to look at for data quality improvement. Sorry if that was a lot of information all at once.
Thanks for that. I hope that answered your question for the person online. So next question, while the number of calls related to cannabis increased, it looks like by far the majority of calls were about other substances. What were these other exposures?
Right, so comparing the calls where cannabis was the only exposure versus the calls where cannabis was in combination with other substances. The top substance from what I remember was Tylenol, actually, or acetaminophen, rather. We saw a lot of calls where the person was co-exposed with that, as well as psychoactive medication. So a lot of times it was people who were taking their routine antidepressant or antipsychotic or anxiolytic medication, and then also took cannabis at the same time. And then we saw a couple of the more, or I don't know the exact percentage right now, but it was a smaller amount that were more illicit drugs. Like we saw a couple with fentanyl, and then obviously for those calls, fentanyl was the primary concern of the call, or things like ecstasy, particularly with teenagers at parties or at festivals and things like that.
Great. I have a question. Leading back to the data quality. You mentioned that you did a data quality analysis with the this cannabis project. How long, can you share how long it took and what were the challenges and what are the importance of having, I guess, good data in order to speed up the process or to ensure that what we present is actually what we present?
Yeah, that's a great question. So it was quite a bit of work at the beginning, but as you mentioned, it's definitely worth it because now going back to it, we have an understanding of how reliable our data is. So when we started off, we took a subsample of the cases that we had and we assessed them for completeness. So for example, for age, we looked at how often was the age category filled out. So for age, sex, for a couple of different factors like that, we assessed them for completeness. We also assessed them for concordance, which means that we compared the coded fields with the case history notes, as we consider the case history notes to be the gold standard at DPIC. So we looked at, for example, the reason for the exposure, the clinical outcome. We looked at whether what was coded in the fields matched what was found in the case notes. And another thing that we did is we also worked closely with a poison information specialist with Dennis to look at some of the fields which were sort of beyond, which required somebody who has a better understanding of things like when to code what symptom and when to code what clinical outcome. And he did an assessment of accuracy of the clinical outcomes and the symptoms with respect to what was described in the case notes. So this took, trying to remember, I want to say that initial part took at least 3 months to do. But Tom, do you remember exactly how long all that took us? 6 months, yeah. It is definitely worth it to do because it means now that the data that we're looking at is more accurate, as accurate as we could make it.
Do you anticipate that with each project like this that we will have to do a 6-month process of data quality analysis?
I don't think each time it's going to take that long again because part of that process was figuring out how to analyze the data. And now that we know how to do that and we have a better understanding of poison center data and what it looks like, I would estimate, depending on the size of the project, that you could probably maybe even half your time. Yeah, depends on what you're looking at. I think each substance kind of brings its own challenges. So with cannabis, we had the issue of the symptoms being things that aren't codable, like high, stoned. So that I'm sure there's specific things like that for other substances as well.
Okay, so the follow-up question for a previous question about other substances. So he actually meant the non-drug calls, so non-cannabis related calls. Were they, I don't know if you have this information, products or other? Oh, yeah, so we have I think we recently we got a list of our top 10 substances, and I think the highest one was acetaminophen was one of them. That was made up, I want to say, like, actually, no, sorry, I can't give you a number, but it was the number one substance by far that was called about. And then I remember ethanol was another one too. That was a big one as well. Do you remember any other ones right now? Mm-hmm. Yeah, those were the two of the major ones that we get called about. Okay. So another question. So did you record if people mixed cannabis with alcohol and not just other drugs or substances?
We do have that information. I didn't present it today due to time constraints, but it did make up, like it was its own category in our analysis, and I could maybe follow up with that person specifically to get them the number.
Sure. Okay. So we'll follow up with you, Carrie, on that question. Okay. Any other questions in the room? Okay, so it looks like there's no questions online either. So I guess that's the end of our webinar, and thank you all for joining us.